By the end of this PowerPoint, 3 things the learner should be able to do are recognize the signs and symptoms of DMDD, identify multiple risk factors associated with DMDD, and identify the appropriate pharmacological and non-pharmacological treatment options for DMDD. This slide provides a pretest consisting of 4 questions regarding DMDD. The answers to these questions will be provided at the end of the PowerPoint in a post-test. Number 1. Which of the following is the most helpful screening tool used to aid in the diagnosis of DMDD? Number 2. Which of the following drug classes is commonly used in the treatment of DMDD? Number 3. Which of the following is a hallmark symptom of DMDD? And number 4. Which non-pharmacological treatment method is used for patients with DMDD? Disruptive Mood Dysregulation Disorder, or DMDD, is a childhood condition of extreme irritability, anger, and frequent intense temper outbursts. It first appeared as an official diagnosis in the DSM-5 in 2013 and is often misdiagnosed as pediatric bipolar disorder because many of the symptoms are similar. The prevalence rates of DMDD are estimated to be between 2 to 5% in children and adolescents, although it is seen much more often in school-age children than adolescents. It is also more commonly diagnosed in males than in females, and for unknown reasons, symptoms do typically remit or improve as children transition into adulthood. Regarding diagnostic and screening tools that are geared specifically towards assisting providers in diagnosing DMDD, there have been none developed yet. This is due to the novelty of it as an official diagnosis. It hasn't been around very long and has recently just been placed in the DSM-5, so they are actually working on creating specific tools to diagnose DMDD. However, Clinicians should rely on accurate description of symptoms and behaviors provided by parents, teachers, and visual observations in the clinic or inpatient settings. The diagnostic criteria for disruptive mood dysregulation disorder, according to the DSM-5, include A. Severe recurrent temper outbursts manifested verbally and/or behaviorally that are grossly out of proportion in intensity or duration to the situation or provocation. B. Temper outbursts are inconsistent with developmental level. C. Temper outbursts occur at least 3 times per week. D. Mood between temper outbursts is persistently irritable or angry most of the day, nearly every day, and is observable by others, for example by parents, teachers, or their peers. E. Criteria A through D have been present for 12 or more months. Throughout that time, the individual has not had a period lasting 3 or more consecutive months without all of the symptoms in criteria A through D. F. Criteria A and D are present in at least 2 of the 3 settings, such as school, home, with their peers, and must be severe in at least one of these. G. The diagnosis should not be made for the first time before age 6 or after age 18. H. By history or by observation, the age of onset of criteria A through E must occur before age 10. I. There has never been a distinct period lasting more than 1 day during which the full symptom criteria, except duration, for a manic or hypomanic episode have been met. Diagnostic criteria will continue on the following slide. Continuing the diagnostic criteria from the previous slide. J. The behaviors do not occur exclusively during an episode of major depressive disorder and are not better explained by another mental disorder such as autism spectrum disorder, PTSD, separation anxiety disorder, or dysthymia. K. The symptoms are not attributable to the physiological effects of a substance or to another medical or neurological condition. It is important to note that DMDD cannot coexist with ODD, intermittent explosive disorder, or bipolar disorder, which we discussed earlier on, that it is commonly misdiagnosed as pediatric bipolar disorder. But it can coexist with other mental health conditions such as major depressive disorder, attention deficit hyperactivity disorder, conduct disorder, and other substance use disorders. So for individuals who do meet symptoms criteria for both DMDD and ODD, you should only give them the diagnosis of DMDD because it can't coexist. Also, if they've ever experienced a manic or hypomanic episode, the diagnosis of DMDD should not be assigned because it's most likely going to be a bipolar disorder. Moving along to the signs and symptoms of DMDD, there are several different areas in which children may display symptoms. Behavioral symptoms may include angry outbursts or periods of rage, fits of aggression toward others or property, behavioral problems in school or at home, bouts of physical violence or verbal aggression. Physical symptoms may include muscle tension, increased heart rate during temper outbursts, or elevated blood pressure. Cognitive symptoms include inability to self-regulate emotions or the inability to refocus attention. Psychosocial
Greetings, my name is April Davis, and I will be picking up where Brennan left off to continue the presentation on Disruptive Mood Dysregulation Disorder in children and adolescents. This slide features a YouTube video entitled The Mental Breakdown, Disruptive Mood Dysregulation Disorder, and it is in affiliation with the PsychReg podcast. This video features Dr. Burney and Dr. Marshall discussing the relatively new diagnosis of DMDD and how these children present as irritable, explosive, and dysregulated. Risk factors that may present itself and may predispose a child to develop DMDD include extensive history of severe chronic irritability, pre-diagnostic presentation that qualified for diagnosis of ODD, ADHD, anxiety disorder, or major depressive disorder at a relatively early age, family history of anxiety disorders, unipolar depressive disorders, and substance abuse disorders, problems with information processing, being a male, family conflict, difficulty in peer or social interactions, acting out or behavioral issues in school, and low socioeconomic status. There are several factors that may cause the development of DMDD. These factors include biological, specifically neurological disabilities, brain chemistry dysfunctioning, and a family history of mental illness. It includes environmental factors, and these are stressful life events. It may be early childhood trauma, such as emotional, verbal, physical, or sexual abuse, recent family divorce, separation, death, or relocation, and diet. Also, prenatal and perinatal factors may cause a child to develop DMDD. Studies show that a connection between a woman's pregnancy and her postpartum experience may cause her child to develop DMDD down the line. Also, maternal depression during pregnancy and or the first few months following the birth of the child may also cause the youth to develop the disorder. Non-pharmacological treatment of DMD is considered the first-line treatment. Psychotherapy, also known as talk therapy, includes CBT, DBTC, parent training, and computer-based training. Of all of these methods, the most commonly used method is cognitive behavioral therapy. CBT teaches children and adolescents how to deal with thoughts and feelings that contribute to their feelings of sadness or anxiety. Providers can also use CBT to teach children how to effectively regulate their emotions and to increase their tolerance for frustration or disappointment. CBT teaches coping skills for regulating anger and ways to identify and relabel the distorted perceptions that contribute to outbursts. Dialectical behavior therapy for children, or DBTC, assists children in learning how to regulate their emotions and avoid extreme or prolonged outbursts. Parent training helps parents to interact with a child in a way that will decrease aggression and irritability while improving the parent and child dynamic. Computer-based training is designed to correct the problem that most youth with irritable mood have, and that is misperceiving ambiguous facial expressions as being angry. Pharmacological treatment. Pharmacological treatment is considered second-line treatment for DMDD. Currently, there are no medications approved by the Federal Drug Administration to treat DMDD specifically in children or adolescents. However, stimulants, antidepressants, and atypical antipsychotics may help relieve symptoms of DMDD. If medication therapy is warranted, providers recommend that both psychotherapy and medication are started simultaneously in certain cases. Stimulants are used to decrease irritability in youth with DMDD. Antidepressants treat irritability and mood problems in children with DMDD. Research studies suggest that citalopram, when combined with the stimulant methylphenidate, can decrease irritability in youth. Please note, antidepressants may increase suicidal thoughts and behaviors in youth and should be supervised closely by the provider. Atypical antipsychotics treat children with irritability, severe outbursts, and aggression. Note, due to unwanted side effects, use is reserved for previous unsuccessful treatment approaches only. Evaluation of treatment outcomes. The DSM-5 task force suggests that individual therapy, in addition to working with the child's family and/or school, and the use of medication to assist in addressing specific symptoms, could be useful for DMDD youths. Treatment for both aggression and chronic irritability includes various medication options such as antidepressants, especially selective norepinephrine reuptake inhibitors, mood stabilizers, psychostimulants, antipsychotics, and alpha-2 agonists. Behavioral interventions consisted of daily social skills training and a reward-based learning program. DBTC, or enhanced care, proved a reduction in DMDD symptoms and disruptive behaviors. A psychotherapeutic program that integrated components of CBT focusing on affects regulation and parent training intervention was effective. Interpretation bias therapy, or IPT, on basic social skills and on learning to negotiate relationally could be relevant to address emotional reactivity and poor tolerance to frustration in DMDD youth. Children with DMDD received stimulant medication for ADHD and were currently receiving counseling services showed a reduction of depressive symptoms. There was a significant reduction of the ABC irritability score after initiation of risperidone. A 15-year-old boy presenting with DMDD and ADHD was successfully treated with naltrexone 50 milligrams daily. Prognosis of DMDD. Disruptive Mood Dysregulation Disorder onset must be before the age of 10 years old. The symptoms are predominantly limited to childhood. Of children who are diagnosed with DMDD, only 19% continued to meet criteria for the disorder at 12 and 24 months follow-up evaluations. Children with DMDD are at risk to develop depression and anxiety disorders as adults. Stages of change model. The stages of change model, also known as the trans-theoretical model, was developed by psychologist James Prochaska and his colleague Carlo De Clemente to explore the ways that people succeed in changing their behavior. This theory is based on several key insights and aha moments that radically shifted the way individuals understand and support the process of behavior change. The stages of change model can contribute to interactions as personal as communications between the provider and the client, and as broadly as applied as a new program or intervention. Important and innovative contribution of this theory emphasizes maintaining change. It is characterized by 6 distinct stages. 1. Pre-contemplation, where no intention to change is there, and the client is unaware of a problem or a risk. 2. Contemplation. The client is aware of the problem and would consider changing, but no specific plans or commitment have been made. They are ambivalent, or they may say they feel stuck. 3. Preparation. Plan to take action soon and may have tried before. 4. Action. Take concrete steps to address the problem, but behavior change is not consistent yet. 5. Maintenance. Generally free of problem behavior, engages in new healthy behavior, and accepts and commits to new behavior as a part of their lifestyle and routine. 6. Termination. Not tempted to return to problem behavior, completely confident in their ability to maintain behavior change forever in any situation. The benefits of the stages of change model when put to use is that it is especially for compelling behaviors, and it can turn setbacks into learning opportunities, which will translate into more lasting progress down the road. Another benefit of this model is that it helps program participants stay motivated and watch them make new healthy habits a permanent part of their daily lives. Here's a link to the National Institute of Mental Health PDF on Disruptive Mood Dysregulation Disorder, the basics. This is the end of the technology project's presentation on disruptive mood dysregulation disorder. Thank you for viewing our projects, and I hope you've learned a lot from it and you've enjoyed watching it.